I am requesting Dr. Momen, please can you s- quick share your slide and go for your presentation
मतलब
within
आप
10
किस
minutes, then we'll be happy because Ashok sitting on the table. Patient condition is not good as, so we have to go for live transmission quickly.
Thank you very much. Thank you,
अच्छा আমি নামাজ পড়ে
Dr.
তুমি তোমার
Azam.
কি করো তাহলে
Thank you, the organizer, BSCI, for inviting me for this presentation. My structural intervention in adults, many more to add.
কত দিয়েছো
Am I audible, sir?
Yes,
Yes,
very
clear
loud
and
and
loud.
clear.
Yeah.
Thank you. Can everyone please mute their mics? There are some background noises.
I am starting with PTMC, and this is the case of severe mitral stenosis, but the patient is dextrocardia. And this is the first dextrocardia PTMC patient reported from Bangladesh. And we are puncturing the patient from the left side, and we parking our catheter in the right brachiocephalic trunk, and it is dragged, Nulin sheet dragged into the septum. And this is the position of the needle in the levocardia patient 6 o'clock position. But in the trick in dextrocardia is the puncture, and the needle position should be in the 7 to 9. And the newer cath lab generated machine producing the mirror image. For that reason, it is easy to puncture, but the trick is the position of the needle. Here we are doing the all things. We push the balloon, and with the J-shaped wire, we fail to cross the mitral valve. So we have to modify the procedure of Inouye procedure. The first over-the-wire technique was failed. Then the second over-the-wire technique was taken with the Moulin sheath, and then we succeeded to enter into the LV, and the Moulin sheath was changed rapidly, and the balloon was negotiated. And this is how we entered the LV with crossing the mitral valve, and this is the procedure. So this is a successful procedure. The mitral valve increased 2 centimeters square, and the medial commission was splitted. And there is only 8 case report in the PubMed search in dextrocardia PTMC. We have done another modification of the standard Inouye technique. We usually nowadays taking the elography in RAO view, and this will help us to cross the mitral valve. And this is the elography in epi view, and this is the elography in RAO view, and this is how it helps to enter the LV. With this 3 modification, we have 80 cases of PTMC, and this paper is going to publish in Indian Heart Journal soon. And we have many ASD cases. I'm sharing some difficult cases. This is the floppy posterior superior rim and floppy inferior rim. We fail from LUPV approach. We fail from the RUPV approach. Every time the device slipped into the RA. So we took the help of a catheter of a multi-purpose catheter in LUPV, and from RUPV approach, we are deploying the devices. So this is one of the technique in difficult cases. Multiple ASD, this is 2 ASD separated by 8 millimeter tissue, and our first attempt was not successful. Device was collapsed through the smaller devices, smaller ASD, and then we make sure that we are through the larger ASD, and then our second attempt was successful, and there is no residual leak. Some special situation, the patient presented with STEMI inferior, and we have done the primary PCR and the right coronary in the radial approach. And on the next day, we diagnosed a large ASD of 34 millimeter. And after 3 weeks, we have done a straightforward 38 millimeter ASD device. This is the case of 18 years old young girl. He's a history of stillbirth 18 months back. He's a cyanosed and clubbing, and there is a room SpO2 at room air is 85%. This is the patient, and look at the pulmonary valve. There is doming of the pulmonary valve, gradient across the pulmonary valve, and there is a bidirectional ASD. So it's a case of severe pulmonary stenosis with bidirectional ASD. We pulmonary valve gradient across the pulmonary valve 54. We have done the balloon valvuloplasty first, and after balloon valvuloplasty, the gradient is 20. We wait for 1.5 months. Still, patient is cyanosed and clubbing, as SpO2 is 88%. There is no gradient across the pulmonary valve, but still there is a bidirectional shunt across the ASD. We decided what to do. We decided to do the cardiac cath. There is no PFVC found, and we measured both pulmonary artery and LV pressure. We done the shunt calculation. There is both step up and step down, as there is bidirectional shunt. And we deployed a 22 millimeter ampulla occluder. Then we again measured the CAT data after 20 minutes, and there is no significant rise of RA pressure. There is no significant decrease of aortic pressure. and the SpO2 increased from 88% to 99% immediately. Then we release the device. And after there is no residual shunt, the patient is doing well. This is the case of 32 years female. This is the case of Lutembecker syndrome. There is a significant shunt across the ASD, and there is also severe moderate mitral stenosis, mitral 1.35. We have done the, this is the ASD. We have done the PTMC first, and after 2 to 3, this is the result of the PTMC, no significant MR. And after 3 weeks, they have done the ASD device closure. And this is the final result of the patient. There is no ASD, only mild MR found, and the valvular area is 2.5, and PSP also. So this is a complex coronary cases. In 52 years male, cardiac autostop of NICVD. He is known for a case of ASD secondary with mild pulmonary hypertension more than 20 years, but he had a phobia of cardiac surgery, now willing for device closure of ASD. But the coronary angiogram routine showing there is a bifurcating Medina 111 lesion of a dominant LCX. We again referred him to surgery, but he refused. Through the transradial approach, 7 French catheter, we approached the coronary lesion first with gel balloon technique, and this is the single stent strategy. And so this is the post dilatation, and this is the final result. This is the final result. And after 2 to 3 weeks, in 3 weeks, we attempted the ASD device closure. Simultaneously, we also measured the LV pressure by pictal catheter in an elderly patient. We always measure before and after the device implantation, whether any rise of LV EDP. This is our 300 case of ASD. Our success rate is 94%. There is no mortality. 1 pericardial component managed immediately. 1 embolization managed by immediate surgery. And my last case is the deadly dealing of a case with highest interventional risk. If we done the intervention within 14 days, the mortality raised from 40 to 70%, but after 2 weeks, the mortality is still high, 4 to 25%. This is a case of STEMI anterior presenting in NICVD thrombolized. On the next, the patient is in cardiogenic shock. Patient has pulmonary edema, gross wall motion abnormality, thinning of the septum and anterior wall, but there is a large VSR in the mid and distal part of the septum, and the VSR length is around 11 millimeters. So there is both LV, systolic and diastolic dysfunction, and severe pulmonary hypertension. The patient is in cardiogenic shock. After shock management on the 7th day, the coronary angiogram with single vessel disease, and we attempted VSR closure on 16th day. This is the VSR. We are trying to cross the VSR from LV, and we finally succeeded. The LV arteriovenous loop was produced, and our first attempt was not successful because we failed to negotiate the delivery sheath into the aorta. So we have to redo the whole thing again with a stiffer wire. Over the stiffer wire, this time we succeeded to cross the delivery sheath across the, this is the delivery sheet, this is the RV, this is the VSR, this is the LV, and this is the delivery sheet in the aorta. And look at the angle what we crossed. It is very difficult to cross such type of angle, acute angle. And this time we have succeeded, and we successfully closed the devices. After device closure, all the parameters included, and this is the smiling face on the 3rd day before discharge of the patient. So, Mr. Chairman, the heavenly smile in the patient face after the successful intervention correction, avoiding the pain of sternotomy and complication of cardiopulmonary bypass is beyond comparison. This is the smile says us what is the relief. So thank you very much. Thank you for your patience.
Momen, thank you, Momen. You rescue us. I must say, Dr. Momen is a young, versatile, and very prominent interventional cardiologist in our young generation, and he shows great cases. I believe everyone, every corner from the globe, from who are sitting in front of laptop and in person, enjoyed a lot.